Obstetric Anesthesia, Diseases in Pregnancy 3, Hernando de Soto. We will talk in this module about maternal hemorrhage, intrapartum, maternal hemorrhage, postpartum, and cardiac diseases in pregnancy. Maternal hemorrhage, intrapartum. Question: which of the following best describes uterine rupture? A. Vaginal infection. B. Fetal bradycardia. C. Painless abdomen. D. Hypertension. E. Rarely requires a cesarean section. The correct answer is B. Fetal bradycardia. It is the most sensitive sign of uterine rupture. The rest of the answers are all false. Vaginal infection is relevant. There's usually severe abdominal pain along with hypotension requiring usual and emergency cesarean section. Uterine rupture may occur pre, intra, or postpartum. Mortality is about 0.1%. Main cause is separation of a previous uterine scar, C-section. Hence the concerns when a VBAC is allowed. And the incidence is much higher with a classical incision than a low transfer incision. Hence, the obstetricians, if they are going to allow a VBAC, then they will only do that for low transverse incisions in the past. Other causes: rupture of myomectomy scars, tumultuous labor, prolonged labor with cephalopelvic disproportion, patients that have had excessive oxytocin stimulation. It's very interesting that maternal mortality is higher if there's no prior uterine scars. So if the uterine rupture happens without a previous uterine scar, then the maternal mortality tends to be higher. Symptoms: vaginal bleeding, severe abdominal pain, shoulder pain, hemodynamic compromise, hypotension, disappearance or fetal heart tones, or fetal bradycardia. Again, what is a VBAC? Is a prior low uterine segment C-section with changes in uterine tone or contraction pattern, fetal heart tone changes, and again, beware, some cases present without pain. So again, VBACs basically when the obstetrician allows a vaginal situation in a patient with a previous C-section scar, they would only allow it if there is a prior low uterine segment C-section. And again, beware that some cases may have a uterine rupture without the patient presenting pain. So look for changes in uterine tone, fetal heart tone changes, etc. VBAC regional is okay. Obviously, there's some hemodynamic compromise than a general anesthetic. Now, postpartum is the most common cause of serious blood loss in the obstetric population. Question: after delivery, a patient loses 1,000 cc's of blood due to a retained placenta. Patient is stable. The OB wants to do a manual delivery. Which of the following is indicated to relax the uterus? A. Ketamine. B. Epidural anesthesia. C. Nitrous oxide. D. Nitroglycerin. E. Midazolam. The correct answer is D. Nitroglycerin. To properly relax the uterus, the patient will need nitroglycerin or the use of general anesthesia. A is incorrect since ketamine may increase the tone of the uterus. B is also incorrect since epidural anesthesia does not relax the uterus. C and E can be used for sedation, but again will not relax the uterus. Retained placenta, the uterus needs to be relaxed again. Nitroglycerin being the sort of the best agent here. Using it intravenously, 100 to 500 micrograms, usually works about 75 to 95 seconds. If you're using inhalation anesthetic, try to use less than 2 Mac. Will do the trigger, but also these patients obviously will have to be intubated because of the risk of aspiration due to a full stomach. If you do regional, there's no uterine relaxation, but can help in the analgesia of the patient, and even hysterectomy may be needed for retained placenta. Indications for these regimens: situations where uterine relaxation may be necessary. You may be called upon by the obstetrician if he needs to do a manual removal of a retained placenta, breech deliveries, multiple pregnancies in which, for example, the second twin might be in a transverse lie and he needs you to relax the uterus, inadvertent oxytoxic overdose prior to delivery, etc. Even some cases of fetal distress. All inhalational general anesthetics, again, the ones that we use nowadays, isoflurane, sevoflurane, and desflurane, all can relax the uterus. But remember, in order to give these, we have to intubate the patients. Nitrates, again, nitroglycerin, it's also been found in amyl nitrate. Inhaled can do it, although that usually is not available in most operating rooms. Beta-adrenergic agents, intravenously, ritodrine, salbutamol, and terbutaline have been found to relax the uterus. The terbutaline works by activation of adenyl cyclase, by increasing cyclic AMP, and also by inhibiting myosin light chain kinase, which is an enzyme that helps in muscular contraction, muscle contraction. So by inhibiting MLCK, terbutaline as a beta mimetic will help relax the uterus. The problems are that it has some very significant potential side effects, like hypotension, tachycardia, hypokalemia, pulmonary edema, etc. Moving on to having an atonic uterus, can happen fairly frequently, up to 5% of deliveries, and a significant amount of blood can be lost in these patients. Can lose up to 2 liters of blood in a fairly short period of time. Again, over causes of atonic uterus, over distension of the uterus, with multiparity, multiple gestations, etc., retained placenta, and excessive oxytocin. You want to give fluids to restore blood volume, blood if necessary, oxygen supplementation, uterine massage, and perhaps more important, uterotonics. Oxytocin, even though its use has decreased significantly, some people still advocate the use of methergin and hemabate as one of the most commonly used for these conditions. IV oxytocin stimulates frequency and strength of contractions. The uterus becomes more sensitive in late pregnancy. Does not respond as well if patients show any signs of hypocalcemia, or if the patient is taking calcium channel blockers. It does decrease peripheral vascular resistance, can cause some peripheral vasodilatation, and hence patients may not feel very well if when oxytocin is used. Hence, the practice that used to happen years ago of giving boluses of oxytocin is no longer practiced. It is much better, obviously, to use continuous infusions of oxytocin. Methergin also increases the force and frequency of contractions, but a lot of people prefer not to use it because it is a very, very, very potent vasoconstrictor with potential hemodynamic and cerebral vascular situations that can be very detrimental to the pregnant patient. Can see rebound hypertension if used with vasopressors, and again, if you use it, I would have some antihypertensive agents available. Perhaps nitroglycerin being a good choice here. The dose of methergine, 0.2 milligrams IM. I would certainly never use it IV. If you use it IM. Hemabate or carboprost, it is 15-methylprostaglandin F2 alpha. Increases strength of contractions, again with increased sensitivity. The more advanced the pregnancy, it causes a mild vasoconstriction. Beware in a patient with preeclampsia, because even mild vasoconstriction can have a significant exaggerated response in that patient with preeclampsia. Problem here being an F2 alpha prostaglandin can cause some bronchospasm. So it can be used in asthmatics and in patients with history of bronchospasm. Just be aware that it can worsen that situation. Dose 250 micrograms IM, or the obstetrician will inject it intramyometrial. Third line treatment would be a drug called misoprostol or Cytotec. It is a prostaglandin E1 analog. It's also used in cases of abortion. The doses administered rectally, 800, 1,000 for placenta previa hemorrhage. Again, also part of the potential treatment for uterine atony there. In patients that have asthma, as we said, the hemabate can be an issue here, and all their side effects like nausea, vomiting, diarrhea, etc. What happens if there's massive hemorrhage here? Obviously, the preparation is crucial, having large bore IVs, blood available, etc. Search for evidence of disseminated intravascular coagulation, perhaps bedside coagulation testing, TEGs, etc. And be aggressive in regards to volume replacement. And if you have blood, obviously blood would be great, but crystalloids until blood is available. Consider packed cells once blood loss is over 2,000. Anticipate the need early. If you need, use unmatched type specific or type O blood. Once more than 80% of blood volume is replaced, you could have dilutional coagulopathies. So again, platelets may become crucial. Fresh frozen plasma, cryoprecipitate, all of these can be used. Uterine massage, oxytocin, ergometrine, ultrasound to detect any kind of retained products, etc. For uterine atony, and surgical exploration for any kind of lacerations, and all the way up to ligation of arteries to perform hysterectomy. Specific therapies that can be used in these patients with postpartum maternal hemorrhage. Angiography for selective embolization of different arteries have been used with good success. Consider prophylactic placement of embolectomy catheters in patients at higher risk for postpartum hemorrhage. Obviously, that is more an obstetrician consideration than an anesthesiologist consideration. And last but not least, the use of factor VII, which can be used as rescue therapy for severe hemorrhage. Last part here would be cardiac disease in pregnancy. Question: which valvular cardiac lesion is best tolerated during pregnancy? A, aortic stenosis. B, aortic regurgitation. C, mitral stenosis. D, coarctation. E, primary pulmonary hypertension. The correct answer is B, aortic regurgitation. Usually regurgitant lesions in general are better tolerated than stenotic lesions. Hence, all the other alternatives are incorrect since they are stenotic. E may be the result of a valvular lesion, but it is not one. Facts about cardiac disease in pregnancy can complicate approximately anywhere from 0.4% to 4% of all pregnancies. It is the major non-obstetrical cause of maternal death. Obviously, you need to know the lesion that you're dealing with and your coagulation status. Remember, obstructive valvular lesions like mitral stenosis, aortic stenosis are very poorly tolerated, and regurgitant valvular lesions, mitral regurgitation, aortic regurgitation, are fairly well tolerated in pregnancy. Mitral stenosis is the most common rheumatic valvular lesion seen in pregnancy, secondary to rheumatic disease. Congenital stenosis tends to be rare. The pathophysiology is restriction of left atrial outflow with reduction of left ventricular diastolic filling and a fixed cardiac output. Remember that pregnant women require adequate diastolic filling time to optimize cardiac output, so tachycardia can be very, very bad in these patients. The pulse exceeds 90 beats per minute, oral or IV beta blockade therapy. Perioperatively for us with esmolol works very well. Continuous infusions of esmolol 50 to 200 mics per kilo per minute may be needed in the perioperative period, and maintenance of high, normal, or elevated wedge pressures, although most of us would not monitor wedge pressures in these patients, but again, to maintain left ventricular filling pressures and cardiac output. Any manipulation of preload, whether it's with diuresis or epidural anesthesia, must be undertaken with very extreme caution. Be very careful with pulmonary congestion and edema and atrial arrhythmias secondary to atrial distension. They may need their atrial kick there. There may be physiological autotransfusion following delivery, and that can produce acute pulmonary edema. As an aside, I would caution mitral stenosis in pregnancy. Be very, very careful because of the potential of pulmonary edema. This is a sort of chart that talks about all four major valvular lesions: mitral stenosis, aortic stenosis, mitral insufficiency, and aortic insufficiency, as to the perioperative situations that are required. I would, for the examinations, I would memorize this chart so that you don't miss any questions on any one of these disease situations. Again, another chart looking at the treatment or the anesthetic management of all of these four diseases. Peripartum cardiomyopathies is a diagnosis exclusion in the U.S. Happens in about 1 in 3,000 births, with very high risk of maternal morbidity, mortality. Once the onset of heart failure in the last month or within 5 months postpartum may be a diagnostic scenario. These patients have an ejection fraction less than 45% and left ventricular end diastolic dimension more or equal to 2.7 centimeters per meter square. Usually no evidence of pre-existing heart disease. Risk factors, the column on the left, usually happens in patients age over 30. Of African descent. There is some association to maternal cocaine use and can be familial. Etiologies, no true etiologies. Some may say there's genetic or prior history of myocarditis, etc. But again, no true etiologies here. Congenital heart diseases and can present with patients with complete repair, partially repaired, or unrepaired, which those have the potential for very, very high morbidity and mortality. Obviously, know the lesion that you're dealing with. Depending on the congenital disease, it'll have some very specific pathophysiologic consequences. Thank you so much.